Congenital heart defect. Basic principle. Congenital defects arise during embryogenesis, usually week 3 through 8, seen in 1% of live births. Most defects are sporadic. Sporadic means non-random problem that may cause a process to deviate from its control limit. Often result in shunting between left systemic and right pulmonary circulation. Defect with left to right shunting may be relatively asymptomatic at birth, but shunt can eventually reverse. Increased flow through the pulmonary circulation result in hypertrophy of pulmonary vessel and pulmonary hypertension. Increased pulmonary resistance eventually result reverse of shunt, leading to late cyanosis, Eisenmenger syndrome with right ventricular hypertrophy, polycythemia, and clotting. Eisenmenger syndrome is high blood pressure in the blood vessel of the lungs and the right side of the heart, with right ventricular hypertrophy. Polycythemia means abnormally high number of RBC in the blood. Clubbing means bulbous enlargement of the end of one or more finger or toes. Defects with right to left shunting usually present cyanosis shortly after birth. Ventricular septal defect. Ventricular septal defect is defect in the septum that divide the right and left ventricle. Most common congenital defect associated with fetal alcohol syndrome result in left to right shunt. Size of defect determine extent of shunting and age at presentation. Small defects are often asymptomatic. Large defects can lead to Eisenmenger syndrome. Treatment involves surgical closure. Small defect may close spontaneously. Atrial septal defect. Defect in the septum that divide right and left atria. Most common type is ostium secundum. 90% of cases. Ostium secundum is a hole in the center of atrial septum. Ostium premium type is associated with Down syndrome. Result in left to right shunt and split S2 auscultation. Increased blood in right heart delays closure of pulmonary valve. Paradoxical emboli are important complication. Paradoxical emboli occurs when a thrombus crosses into a cardiac defect into the systemic circulation. Patent ductus arteriosus. Patent ductus arteriosus is failure of ductus arteriosus to close, associated with congenital rubella. Result in left to right shunt between the aorta and the pulmonary artery. During development, the ductus arteriosus normally shunt blood from the pulmonary artery to the aorta, bypassing the lungs. Asymptomatic at birth with continuous machine-like murmur may lead to Eisenmenger syndrome, resulting in the lower extremity cyanosis. Treatment of patent ductus arteriosus involves indomethacin, which decreases prostaglandin E, resulting in patent ductus arteriosus closure. Prostaglandin E maintains patency of the ductus arteriosus. Tetralogy of Pilot. Tetralogy of Pilot is characterized by stenosis of right ventricular outflow tract, right ventricular hypertrophy, ventricular septal defect, and aorta that override the ventricular septal defect. Right to left shunt lead to early cyanosis. Degree of stenosis determine the extent of shunting and cyanosis. Patient learn to squat in response to a cyanotic spill, increase atrial resistance, decrease shunting, and allow more blood to reach to the lungs. Boot-shaped heart in X-ray are seen. Transposition of the great vessel. Transposition of the great vessel is characterized by pulmonary artery arising from the left ventricle and aorta arising from the right ventricle. Associated with maternal diabetes. Present with early cyanosis, pulmonary and systemic circuit do not mix. Creation of shunt allow the blood mix after birth is required for survival. Prostaglandin E that can be administered to maintain patent ductus arteriosus until definitive surgical repair is performed. result in hypertrophy of the right ventricle and atrophy of the left ventricle. Truncus arteriosus. Truncus arteriosus is characterized by a single large vessel arising from both ventricles. Truncus failed to divide. Present with early cyanosis, deoxygenated blood from right ventricle mixed with oxygenated blood from left ventricle before pulmonary and aortic circulation separate. Tricuspid atresia. In tricuspid atresia, tricuspid valve orifice fail to develop. Right ventricle is hypoplastic, often associated with atrial septal defect, resulting in a right to left shunt present with early cyanosis. Coarctation of the aorta. Coarctation of the aorta is narrowing of the aorta classically divided into infantile and adult form. Infantile form, adult form. An infantile form is associated with the patent ductus arteriosus. Coarctation lies after distal to the aortic arch, but before proximal to the patent ductus arteriosus. Present is a lower extremity cyanosis in infant often at birth, associated with Turner syndrome. Adult form. Adult form is not associated with the patent ductus arteriosus. Coarctation lies after distal to the aortic arch. Present is a hypertension in the upper extremity and hypotension with weak pulses in the lower extremity. Classically discovered in adulthood. Collateral circulation develop across the intercostal arteries and gorge arteries cause notching of rib in X-ray, associated with bicuspid aortic wall.